Good afternoon, and thank you for joining us for our Healthy Transitions Colorado January 2015 webinar. My name is Ann Kokish with the Colorado Healthcare Association, and I'm very happy to be here today with you to review and discuss using the Post-Acute Transitions Program. It's a readmission reduction strategy for high-risk populations. Healthy Transitions Colorado is run by operating partners, the Colorado Healthcare Association, Telegen, formerly CFMC, the Colorado Hospital Association, and Colorado Rural Health Center. It is managed by the Center for Improving Value in Healthcare, CIVIC. Healthy Transitions Colorado is a collaborative effort focused on aligning and accelerating existing efforts to improve transitions of care for Coloradoans. Our guiding principle is that by breaking down the silos of healthcare, we can foster true community care coordination across facilities, specialties, and practices. Healthy Transitions Colorado coordinates the tools, resources, and efforts of many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. Our goals for this campaign follow the triple aim. Over 2 years, we hope to eliminate 8,700 readmissions, eliminate over 34,000 days in the hospital, and save $80 billion for Coloradans. If you haven't already done so, we'd like to invite you to become one of our community partners and take the pledge to improve patient care transitions. To take the pledge and learn more about HTC, visit our website at www.healthy-transitions-colorado.org. I have just a couple of things before we get started. The phone lines have been muted and will remain so throughout the webinar. We'll be using the chat feature available in the lower left-hand corner of your screen to field questions and allow you to make comments on the discussion. Questions posed to the presenter will be answered during the Q&A session after the presentation. This webinar is being recorded and will be posted on the Healthy Transitions Colorado site, so you may access the information again at any time with no cost. I'm now going to turn the program over to Jody Smith. Jody graduated from the University of Colorado Health Sciences School of Nursing and Master's Doctoral Program, which the last 3 years has been developing and implementing the PACT, Post-Acute Care Transitions. It's a home visit program targeted at high-risk hospital discharges for Kaiser Permanente, Colorado. Jody, thank you for being here today.
Thank you so much. I'm so happy to be here and talk to you about PACT and what Kaiser's doing to look at readmissions and see what we can do to make the experience of our members discharging from the hospital better and truly triple aim, from a high quality standpoint and affordability not only to our members but our organization. I'm going to start with an in-depth review of causes of 30-day readmissions. The study looked across 18 hospitals, and we all know that there are preventable reasons for readmissions and unpreventable. So you come into the hospital with heart failure, and within 30 days you get in a car accident. Those are things that, despite all of our best efforts, we will be unable to prevent. But this study really showed, and I want to really just kind of call out the 47% of readmissions were potentially preventable, and I want you to remember that number for later in the study, but that says that everybody that comes back within 30 days, there was the potential for preventing that outcome. One thing our region in Kaiser has been able to do very successfully is implement a risk stratification methodology for looking at, I'm sorry, next slide. Yes, thank you. A risk stratification methodology so we can be targeted and mindful of our population. Next slide. We landed on LACE. There are many risk stratification tools out there. LACE kind of was a really good fit for us in our region. It was developed in Ottawa, Canada, where a single payer has kind of an integrated delivery system and manages their members. The original study looked at 1 million patients and 48 different variables on why people come back. And the LACE model is a tool to predict 30-day readmissions and death rates. So like I said, 48 variables were looked at. It included living situation, age, functional limitations, medications, polypharmacy, comorbidities. They even looked at season of hospitalizations and readmissions and others. Four variables were found to be the most powerful predictors and kind of mathematically boiled down to predicting 30-day readmission and death. L stands for length of stay. So kind of thinking about the longer you're in the hospital, it's a proxy for acuity, and so L stands for length of stay. A is for acuity of a visit. Did you come into the hospital through the ED, or is this a planned elective total joint? C stands for comorbidities. It uses the Charlson Comorbidity Index. And then E stands for ED use within the last 6 months. So kind of thinking that past behavior predicts future behavior. It spits out a score. The tool goes from 0 to 17. The higher your score, the higher your risk of readmission or death within 30 days. And one thing I like to say about this is there's a lot of a risk of a prediction tool is just that. It's just a tool. It's a point of departure. It's a quantitative way as a provider for you to validate your gut, that you are worried about your patient, and this helps with that. Next slide. So we laced an entire population at baseline and retrospectively went back to hospital discharges, gave everybody a LACE score, and then looked at their readmission rate. And so we found mathematically that there were clear delineations around LACE score within our own population. So a score of 1 to 6 is considered low risk. They're as a risk pool, their readmission rate is 4.5%. A 7 and 8, they're kind of this moderate risk where, we're not comfortable with a readmission rate of 8.7 or 8.9. I think there's some things we can do. But then clearly 9 and greater of a LACE score, we considered high risk, and as a risk segment and a risk pool, their readmission rate is 25%. So this is our baseline. We looked at this and then said, so now what? What can we do? So we concentrated our efforts on the 9 to 15 risk pool, the high risk pool, due to the fact that they had different needs and they needed more and maybe an added layer, added interventions. And we found great opportunity to impact the outcomes of this high risk group. Next slide. When I was asked to implement PACT a few years ago, I said, great, what's our readmission rate? And at the time, I think it was like 10 or 11%. And I said, well, that's really good. Medicare national readmission rate at the time was like 22. I said, I think we're doing pretty well. But what risk stratification allows you to do is be a little more mindful and targeted and realize that if your readmission rate is 10%, that's just an average. So the higher your risk, the more support patients might need in transition from hospital. And if it's an average, half your population in theory is higher than that and half is lower. At the time, we had one strategy. Everybody that left the hospital got a phone call from a Kaiser nurse and saw their doctor in 3 to 5 days. And so it made us look more closely at that. A LACE of 4 does not require the same level of care as the support or a LACE of 14. And like I said, we had kind of a one-size-fits-all strategy. Next slide. So we segmented and risk stratified our population, and that enabled us to tailor the care according to risk and be really, really mindful. Next slide. So we segmented our population into low, moderate, and high risk, and then implemented care pathways according to that risk. So for example, if you are a low-risk member discharging from the hospital, you get a transition call from a nurse care coordinator within 72 hours of discharge, and they do a wonderful job of doing telephonic med rec. They validate and confirm follow-up appointments. They can always override to a higher level of care if if we don't think this LACE score kind of meets the need, because again, it's just a tool. But one thing we recommended in the low risk segment was trialing phone visits. So following discharge from the hospital, you're a LACE of 4. I think your primary care doctor can meet your needs telephonically. So this had huge implications for access. The moderate risk pool, they got everything the low risk pool got, except that instead of telephonic follow-up with your doctor, we think you should probably go in and be seen. And then high risk, and that's going to be the focus of PACT and this talk, is they get the same as everything low and moderate and coordinated in this care pathway, except they get a PACT visit, which stands for post-acute care transitions, within 72 hours. And then we either put that primary care appointment out, or depending on what the PACT nurse practitioner finds in the home, they can either move up or back that follow-up appointment. Next slide. So this is a visual illustration of the care path for our high-risk members. Like I said, we had a one-size-fits-all strategy before the implementation of PACT, and it was very front-heavy. So they got a wonderful, robust phone call within 72 hours, but they all saw their doctor within 3 to 5 days. And then it was really variable around what happened day 6 and greater. So because they were high risk, we wanted to add an extra layer of support for these members in transition. And so this kind of visually illustrates what a Kaiser member that's high risk can expect from our system. So within 72 hours, they get a PACT visit, and those visits last an hour. And they do in-person medication reconciliation, which I'll get to later. They do a physical exam. They can order labs. They can order medicines. They can and then coordinate the care. Then we want them to see their doctor, depending on if everything's kind of stable, and we allow them the tincture of time to just heal from their hospitalization and continue the care plan set forth in the PACT visit and the discharge. Then there's the thought that if the care coordination nurse, the care coordinator nurse, can call them on week 2 and 3, and this population is involved in the CCM, the NCQA QI7 complex case management population, where they're going to do disease management resources and talk to the patient about their care plan. Next slide. So this PACT is in some ways very simply going back to our roots in medicine around doing house calls. And so Kaiser's mission these last year or two includes the words meeting our members where they're at. So literally, figuratively, we go to them, meet them where they're at in their home environment, and do an hour-long transition visit in their home. Next slide. So PACT is a new model for Kaiser, and it's modeled after the great works of the Care Transitions Intervention with Eric Coleman and the Mary Naylor model through Penn State. But by coupling a robust readmission prediction tool, LACE, with strategically designed post-discharge home visit PACT, we have been able to significantly reduce the rate of readmission in this risk pool. Next slide. Like I said, PACT is a nurse practitioner rounding team, and it's a single home visit within 72 hours of hospital discharge. I always like to say that it's a specialty consultation. It is not home health, and it is not a clinic visit where you have to get all this done in 20 minutes. And this only you only qualify for PACT if you are considered a high-risk member, and it's conducted by nurse practitioners internal to Kaiser, which is a real. I think that's underestimated how important that is for our integrated delivery system, for the nurse practitioner to be able to order labs in our system, coordinate and discuss follow-up with the care coordinator teams, the primary care doctor, the pulmonologist, the cardiologist. It's really important, because I've been in my previous world outside of the world of Kaiser, and it's a very robust system, but it's also a pretty difficult system to navigate. Next slide. So I always get asked, why does PACT work? And I really think that it's just it's investing in people to partner with patients and walk through this difficult time with them. I always say it's the right message in the right place at the right time. I prefer not to do or have my team do PACT visits on day one in 24 hours, because patients get home and they don't know what they don't know yet. They've opened their mail maybe, and they've paid a bill or two and fed the cat, but they really haven't gotten to the discharge instructions. So around 48 to 72 hours to come into their home, they've struggled maybe for a day with the instructions, they have some questions, and then this nurse practitioner, Kaiser provider, shows up in their home and is able to just really, it's a really rich time to have these discussions. In Colorado, in Kaiser, we contract with our home health services. And so prior to PACT, for coordination and management of our complex members, home health services were the sole providers in that gap. And to be fair to them, they didn't have access to the medical record, and sometimes they just had a sheet that said, home health nurse for med management or something. And so home health should augment the care versus being the sole provider in the post-acute time frame for complex members. There's a lot of complexity in chronic illness management and titration that in these high-risk members they need that integrated team, is my belief. Our home health partners are extremely expert in providing skilled care in the homes with wounds and IV and ostomy and therapy. And we found that management of this high-risk group required just kind of that integrated high-level wraparound systems and providers to mitigate readmissions, improve communication and outcomes for our members and our organization. Next slide. This is a Far Side cartoon, and I think you've all probably seen it, but the guy is saying, bad dog Ginger, stay out of the trash Ginger, very, very bad dog Ginger, but all the dog hears is Ginger. Well, what I noticed sometimes when I would do PACT visits is patients didn't hear much. They heard cancer. They heard heart failure. And the difference between what you say in the hospital and what patients heard is often lost in transition. So how do the words like cath lab and heart failure translate into what the patient actually needs to do for their health when they get home? Next slide. So the PACT visit has several domains in what we do in that visit and what I charge my team with doing in the home. And they do an objective empirical assessment of the patient in their home. So anything from physical assessment to kind of home assessment to are they failing, are they eating, those kinds of things. Ensuring and being in the home, I just want to say, is such a privilege, and it's very intimate, and it's an honor to be invited into our members' homes and get to sit at their kitchen table and talk to them about their health and their medicines, and you hear what they really think about their doctors. They really love their doctors, and then you hear from doctors they love their patients, and sometimes it's just a square peg, round hole kind of thing where you need these long conversations. And one of the things that the PACT nurse practitioner is charged with doing is ensuring proper follow-up. And so often we would find cardiology and primary care doctor visits on the same day. So we want to spread out touches over time. So we would coordinate that and cancel one appointment and reschedule it for a week later. The intensive in-person med-rec and management is kind of the bread and butter of PACT. I'm going to talk about med-rec here in a few slides, but even in an integrated delivery system, it's humans entering this into our medical record, right? And so med-rec is not just about making two pieces of paper match. It's really about sitting at the table with the patient and their pill bottles and their discharge summary and their med list from their medical record and going through that in depth with them. And then once everything's reconciled, asking the patient, so what are you doing with this med? What's your goal for taking this med? You're on 3 antihypertensives. Do you know what that means? And what's your goal? The next one is patient education and engagement, so education about the Kaiser system, about resources, about their disease, and then engaging them. So for example, we got our start in the heart failure population, and when a patient goes home with heart failure, there's a lot they need to do. They need to stop salt. They need to weigh themselves every day. They need to take their medications at certain times. They have fluid restrictions often. And so when we get out there 48 to 72 hours, we push that appointment back a week or 10 days, and we say, for this next week, I want you to weigh yourself every morning, do this, and then we order labs and then say, and then go see your doctor. So when they see their doctor, the labs are in the system. They have a week's worth of data, and it's a much richer appointment, follow-up appointment with their doctor with that data in hand. We use nurse practitioners because they're able to assess and treat post-hospitalization complications or treatment failures. I'm just going to use heart failure as another example. Patients, will take 5-7 kilos off of people sometimes, and through their entire hospitalization, we've been pumping them full of IV Lasix and diuretics and saying, restrict your fluids, restrict your fluids, restrict your fluids, and they're peeing out gallons a day. And then when they get home, they're still taking Lasix, but guess what? They've all stopped drinking water. And so many times I would find that patients were really dry. They were, believe it or not, we just took all that fluid off of them, but now they're hypotensive, tachycardic, and barely taking sips of water in a whole 24-hour period. And so really kind of doing real-time education with them on that. And then the other thing that the PACT team is really good at doing is referrals to our community specialists, our care coordination teams, our disease management teams, Meals on Wheels, those kinds of things, and then ordering labs and titrating meds is another reason we use nurse practitioners. And next slide. One of the reasons I think there's a key to success is that it's one-on-one with the patient in their home environment. For some reason, they just can hear you when they're home. They've just had this traumatic experience of landing in the hospital. They're tired, and they're comfortable and relaxed now, and it's just a really powerful experience to be with them in their home. The tincture of time, complexity requires it, and so do our patients. So the average time for a PACT appointment is an hour. There's a lot of high level of ownership. So my PACT team all has cell phones, and they consistently give out the phone number. Here is my number. Please call me if you have any questions after I leave, or if you think you're headed back to the hospital, give me a call and we'll see what we can do. PACT not only pays for itself, but it contributes quality and cost metrics back to the organization. It is the quality improvement plan we've submitted to CMS, and PACT is heavily involved with, in addition to our care coordination teams, with the QI7 and NCQA. And like I said earlier, it's truly triple aim. Next slide. I'm going to go a little in depth with medication reconciliation because, like I said, it's the bread and butter. And next slide. And I'm showing this photo to illustrate that even in an integrated delivery system with a top-notch electronic medical record, medications can quickly get out of hand when you have multiple providers, different formularies, several care transitions. The patient is the only common link navigating our complex system and systems, multiple systems. Therefore, any attempt to improve care transitions and improve medication reconciliation should have the patient at the center of that, because our list when I say our, I mean Kaiser's. We can think we have the best list and updated list and clean list in KP Health Connect because we reconciled that with the discharge summary. But until you're sitting at their table and seeing that they are taking the wrong dose or half a dose, or they haven't picked it up, or they're taking duplicative medication duplicative medications. They're taking their metoprolol and their atenolol. You really, really get a sense of how important MedRec is. So this is a patient that you can see that, instead of twice a day, their hydralazine got changed to 3 times a day. Amitriptyline had been discontinued, but it hadn't been in the medical record. They were done with their Cipro. They did not pick up their IMDR, their isosorbide mononitrate. The atenolol had been discontinued. Their Lasix, their furosemide, was on hold because they were dry and hypotensive. But it doesn't really have instructions on when to restart it. And then lisinopril had been discontinued, and then amiodarone was ordered, and it's nowhere even on the list and wasn't on there. So even though we've got this great system, integrated delivery system, and this wonderful electronic medical record, this can be a very typical medication reconciliation that we do in the home. Next slide. Here's some more examples and photos. The one in the top right, it says SBP, and the patient asked me, they're like, what is SBP? Because it says SBP is greater than 100. And they had no idea what we were talking about. Well, that's systolic blood pressure, and so the patient didn't even know how to use this medication. Then on a discharge list in the top left, that's the same medication with 2 different instructions. I have, unfortunately, example after example after example of medication discrepancies that I believe, if not caught, reconciled, and taken care of, that it would lead to another hospitalization. For example, the patient was taking a double dose of beta blocker, and unfortunately this is fairly common, where the discharge instructions stated metoprolol 25 milligrams, take 2 tabs twice a day, so that's 50 milligrams twice a day. The patient had 50 milligram tabs at home and was taking 2 tabs, so in essence they were taking 100 milligrams twice a day, 200 milligrams total. At my visit with them, their pulse was 46 and their blood pressure was 96/48, and he was like, I just can't get out of my chair, I'm just so tired, and so and that's a really important part of this. And so we, went back to the original dose. We held it that night. I called him the next morning, asked for his blood pressure and his pulse, and we got him kind of straightened out. Another one is discharge instructions stated stop the amlodipine and start metoprolol. At the PACT visit, the wife was giving the patient, both medications, even though it was clearly stated. And I think when I talked to her, she smiled and nodded, yeah, like, yes, I know. And then I looked in the pill box, and both were loaded in the pill reminder box. Another example is patient admitted for low hematocrit and a possible bleed. At the PACT visit, it was noted that the patient was taking a combination med for headaches every day that included Tylenol and aspirin, and it was discovered that the patient was taking 750 milligrams of aspirin daily. Last example, although I have dozens and dozens and dozens, patient with multiple admissions related to falls and confusion. At my visit with him, it was discovered that patient was taking twice a day Benadryl for a drippy nose. And Benadryl is one of those Beers meds, Beers criteria meds that is an absolute no-no in the elderly because of its really, really strong anticholinergic effects. And this was not listed anywhere in the medical chart or the discharge summary because nobody knew. And so some of this stuff can't be done in quote-unquote artificial environments like the hospital or over the telephone unless you're saying, can I look in your med cabinet and can we go look through this together, and what else are you taking? Until you are able to do that, it's so illuminating on what members are doing out there in their homes, in their medicine cabinets, at their kitchen tables. For better or worse, they are self-managing, and it's wonderful to have a partner that can do that with them. Next slide. This is another cute cartoon where polypharmacy is a real issue. When I was doing the care transition intervention randomized control trial with Eric Coleman back in the late 90s, early 2000s, patients were taking on average of 8 medications. Today, in the PACT high-risk risk pool of the patients that PACT touches, that number has risen to 14 medications on average per member. So I think as we have more medicines, we have more to prescribe, and I think that polypharmacy is a real contributing issue and a problem. I think once you get up to 14 or 20 medicines, you actually, we actually don't know pharmacokinetically and pharmacodynamically what's happening in that patient. And so we have really strong partnerships with pharmacy too to see if we can get them involved in taking looks at what we can stop. Okay, so next slide. After all is said and done, we target them, we risk stratify them, we do these visits and spend an hour with patients. We do comprehensive medication reconciliation and really mindful care coordination around spreading out interventions across 30 days. Next slide. As you'll remember from the previous slide when I was showing LACE, the baseline readmission rate for the high-risk pool by LACE score was 25%, and current PACT performance is 11.5%. And so that's a 60% reduction in readmission rate of the high-risk group. And if you'll remember on that first slide where I said please pay attention to the 50% of that meta-analysis, and I said please pay attention to that 47, 50% percentage of that readmissions were preventable. I think that PACT is helping to mitigate those preventable reasons of why patients come back to the hospital. The PACT performance has been sustained for over 2 years. Some months it's 6%, some months it's 14%, but 12% has just been this kind of rock solid outcome for PACT, and it just hasn't wavered. And so we're targeting the high-risk inpatient discharges and reducing the readmission rate by 60%. Next slide. This is our Medicare over E rate for the Denver-Boulder region, and it's our readmission rate. PACT sees everybody, so we see commercial, we see Medicare, we see SNP and Medicaid. So there's no exclusions for that. And the red line is where PACT was implemented in our region. Now this is clearly just contributory. It's my belief system that PACT is contributory, but it is not solely causal. There were other things in our region in Kaiser happening during the same time with an intense focus on care transitions. We had incredible engagement from our hospital partners where they were doing this whole new medication reconciliation at discharge. Our care coordination teams in Kaiser were looking at their protocols and their exclusion criteria and working really closely with specialty teams. So again, contributory, not causal, but it just shows the impact of when you target high-risk segments of your population and do things differently, you can have real concrete outcomes. Next slide. One thing that we are starting to look at, and this is going to be my social commentary and my opinion, solely my opinion, is that as a nation, as healthcare systems, as healthcare insurers, as people paying for healthcare, as consumers of healthcare, we have to get real about readmissions. And we right now CMS just looks at inpatient to inpatient, and that's only a third of all types of reasons people come back to acute care. And so really looking at emergency room utilization, OBS admissions, and inpatient utilization. PACT has been able to significantly reduce all three, and But right now, what people present when they're talking about the readmission rate is really just inpatient to inpatient. But with the increased utilization of observation status, it's a little harder to become inpatient. And so OB status is going to be and ED usage is and should be included in any look at your organization's readmissions, because what that tells us is are the needs of your members or your patients being met outside of the walls of a hospital? And so it's really kind of getting real, making your readmission rate look as bad as it can, and then asking yourself what you can do. PACT measured patient satisfaction, and we actually stopped because it was stopped being useful. Patients absolutely love this service as a whole. I've been thrown out of one home where she was like, I don't need you, I don't need your help. But in general, I get hugs and kisses, and people want to give me cakes and cookies. And it's just one of the most rewarding things of my career to be able to do is go into people's homes, and it's my privilege to talk to them about their health. So very, very high patient satisfaction. Upstream and downstream provider satisfaction from knowing that PACT is an extra layer of support. And then this saves on other costs where we're coordinating the care with specialty and home health follow-up. But previous to PACT, we would send in home health, and now we can own a certain segment of our population with PACT and have great outcomes. Next slide. So in 2015, it's already on my personal goals. We are expanding PACT to SNF discharges. And this is an illustration of the baseline readmission rate for those discharges. So on the left, and it's by risk pool. So green, that kind of gray color, is the LACE 0 to 6. The tan beigey color is the LACE scores 7 to 8. The brown color is LACE scores 9 to 15. And the blue is the LACE scores 16 and greater. And the graph on the left is 30-day readmission rate from the index hospital discharge. So if we're looking at the same risk pool, 23% of those SNF discharges are readmitted. And on the right-hand side, those are the 30-day readmission rate from the clock starts ticking on the date of the SNF discharge, and that's 30%. The blue is a little misleading. I mean, what we as a region need to do next is focus on the LACE of 16 and greater, because those needs, there's a different skill set of needs needed for that risk pool, where it's palliative care support either in the clinic or home base. A lot of times it's placement issues, and patients are just in the trajectory of figuring that out, and it's hard to spend down, and it's hard to imagine paying $4,000, $6,000, $8,000 a month. So that's that trajectory. But we're going to, in 2015, PACT is going to focus on SNF discharges with the same LACE scores of 9 to 15. Next slide. And again, I guess I already spoke about this, but really, really important, I think, is include all acute care returns in your readmission analysis. I feel very strongly about this. When you say your readmission rate is 8%, 10%, 12%, which our region is, and that's what we kind of solicit or we report, but it's commercial, it's planned total joints, it's everything, and so in some way target and risk stratify your population, watch all acute care returns for 30 days, and then ask yourself what you can do, and ask yourself if you're able to take care of the needs of those patients outside the walls of the hospital. Next slide. So in conclusion, the reason we're all here, and it's all over the literature and every journal you read, and Every conference seems to have something on readmissions, and it's because it's time for us to look at them, and it's time for us not to just keep paying and or do things differently, or Medicare has really kind of led the charge on that, and so they're very common. 50% of them are potentially preventable, and I think the average cost of a Medicare readmission these days is around $10,000, and so that adds up. Risk stratify your population and target your interventions accordingly, meaning for us it was that we had a one-size-fits-all strategy, and so now we are able to be a little more mindful and targeted, where a CHF, a heart failure member with a LACE of 4 does not need the same level of intervention and support as a LACE of 14 with heart failure. And so it's able to kind of target your resources to the people that need you the most. Communicate the same plan to the patient first, and get on the same page there, and then communicate that to all downstream providers that are involved in the care of your patient. And then I think if you partner and keep the patient at the center of all you do, I think that's what's gonna make the difference here. Next slide. So I'm happy in the chat in the lower left-hand corner to take any questions. Thank you so much for having me and listening today.
Gosh, Jody, what a really impactful presentation, and thank you very much. There is one question in the corner. It says, how do you handle those situations where the PACT meeting shows that the patient is not capable of following through on discharge orders, and those support services are not currently in place?
That's a great question. Those are those PACT visits you do and you leave and you're like, I don't know. You just don't feel good, or like you're impactful, and you just go down trying. You spend a lot of time referring and communicating and referring to any and all resources. I think our home-based palliative care programs are kind of they're a very important partner to us in PACT, because they can come to the patients. We have homebound rounding teams. I try and include any family member that's around and possible. I will schedule my appointments if it's possible for the son or daughter to be there. It's really important to include their support system. If there's no support system, those as a provider don't feel good. I've done PACT visits in people's driveways because they were such horrific hoarders that you couldn't get through the front door. I've done a PACT visit, and a guy lived in a closet at an auto mechanic shop. I've done PACT visits in hotels where people are kind of homeless, and we discharge them to a hotel. So it's hard, and what we can own is that transition. So I'm going to make these I'm going to make this next hour about you. I'm going to set in plan, and you have shorter term goals initially, where it's like, I just want to get you through the next 3, 5, 7 days, and I'm going to talk to your doctor, and I'm going to try and plug you into programs where we're just going to go down trying. Sometimes, I've always said this, it's really hard to cure a social problem with a medical solution. So I just pull everything at my disposal at them, and we just try. It's a great question.
Great, thank you. The question from Barbara: what is the general age of your population?
The average age is 76 years old.
Great.
In the line of business distribution, I can't remember if I said this, but we see about 80% Medicare and 20% commercial and Medicaid. But my thought is I would recommend you don't exclude. I think there's a lot of focus on Medicare because our average age is 35. But if you're at risk, you're at risk. I don't care if you're 64 or 35. They need us too.
Right. How do you get patients to agree to the home visit, or do you meet with a lot of resistance?
Oh, that's a great question. I'd say in the beginning it was a little more complicated, or it was a little harder than it is now because as a new program, there were people in Kaiser that didn't know about PACT. So we've really, really partnered with our hospitalists, and when their doctor in the hospital is saying, I'm ready to discharge you, and I'm going to order, I'm going to have a nurse practitioner come to your home in a few days and go over some things with you. It goes a lot smoother. People always will refuse, any intervention really. We recommend you go to SNF. We're thinking you would benefit from palliative care. There's a small percentage of a refusal rate we have, but in the most part, I would say as a general rule, people really value this caring and this intention of coming to them, and they don't have to 2 days after, 3 days after their hospitalization, get up early, get dressed, pack up, drive to their doctor's office, sit in a waiting area for 20 minutes, then wait their doctor 20 minutes. I mean, they're tired and sick, and they really, really appreciate it.
Thank you. Is the PACT program coordinated with the Kaiser perinatal home care program?
Oh, those are my dear friends. I love that group. So not coordinated because they're seeing healthy, normal people. They do visits on the perinatal home care program is also a nurse practitioner rounding model at Kaiser that rounds on them in the hospital and then does home visits after birth. Same thing within 72 hours, and they see all moms and all babies, and they have wonderful outcomes, and they're an incredible team. So there's no coordination between the two, except they're modeled very, very similarly. I mean, the only difference is we're seeing high-risk sick folks, and we just see different populations.
Great. Do you follow only patients out of the inpatient setting, emergency room, OBS or whatever, or are you tied to certain physician groups to identify high risk prior to a hospitalization?
So we do see discharges. Primarily, we started with inpatient discharges. We just had, when we started this, I was the only nurse practitioner doing this, and then we got 1.5 nurse practitioners. So we just focused on the high-risk segment of inpatient discharges. And then we do, OBS discharges do kind of leak in, and I think if they're lacing out and they're an OBS patient, they're clearly at high risk. We haven't expanded really to ED discharges. We're going to start with SNF first, and then we're going to go to ED. We've done risk stratification in the emergency department because LACE doesn't really work there because they don't have an L really. There's no length of stay. And so we've used the ISAR tool to risk stratify the ED population, and guess what? The higher your ISAR, the higher your risk of readmission, and we know that baseline readmission rate. So that's just going to we're just going to need more resources to focus on that population. That's coming. And then, are you tied to certain physician groups to identify those high risk prior to a hospitalization? So no, I think as our region we're looking at certain measures, the LOH, the likelihood of hospitalization to kind of target. That's going to be another focus of hospital operations in certain groups within Kaiser to look at that pre-hospital space. So what can we do to prevent an index hospitalization? I think that's really going to be an important thing to look at, and I think we're going to use the LOH score, look at some maybe community paramedicine programs. We have newly configured care coordination teams called CMTs. They're going to do embedded in the doctors' clinics to kind of manage complexity to mitigate risk and just improve quality and all sorts of measures. So, being Kaiser, we're all in an integrated delivery system, so we're all working together.
Great. Do you refer to Adult Protective Services if that's indicated?
Absolutely. Yeah, I mean, when we're in the home and it's clear that it's really bad, Absolutely. Yes.
And then how do you handle delicate situations when they arise with physicians regarding overprescribing of medications?
You know, I'm just I would call people all the time and clarify, and in the spirit of learning, and we all have the patient at the center. So I never felt I, I, me personally, I just never felt scared or to approach that like, boy, I'm confused and I can't figure it out. What did you mean? And okay, I did this, and I think they're human, and I think they make mistakes, and I think that's why we all exist: patients, families, PACT, care coordinators, nurses in the clinic, call centers. That if a mistake happens, like I would want to know about it, but I want it to be in the spirit of learning, and not like, how dare you, you horrible person, you didn't do your job. I think we all want to do what's best for patients, and it's just having that partnership and that collaboration and the patient at the center. I really, truly believe that I've never had anybody bite my head off because I was looking for clarification.
Mm-hmm. How do you get the staff to become involved? This person says, we have been doing home visits for 2 years now, and there's been a lot of kickback from staff. They are not wanting to or feel comfortable to go. This includes nurses and providers. They have a mindset to, you're going to put that down, I can't see it, a mindset for scheduled with home health.
They have a mindset.
I'm not exactly clear what the question is.
They have a mindset. Well, I kind of, it takes a certain person to do all things, right? It takes a certain person to work in SNFs, to work in pediatrics, to work in wound care, to be a cardiac surgeon. And so I think this would be outside of somebody's comfort level, because in your bricks and mortar or in your clinics or your hospitals, you can control it, right? But honestly, it's not until you see the barriers facing patients that you get why they've been to the ED 6 times in the last month. It's a very powerful thing, and so I would ask the staff around, what are their fears? I mean, I've been in some really horrible homes. I say PACT is a socioeconomic service for Kaiser. We go to trailer parks mostly, trailer parks and apartment buildings. I mean, we're not going to the penthouses of Cherry Creek. So you have to kind of be comfortable with wearing like not pretty clothes, and not drive up in a trailer park in your Mercedes SUV. I mean, there is a certain kind of demographic of the PACT provider. But I will tell you that every one of my staff think that it's the most rewarding job they've ever done in their career, because as nurses, not only do they have the time with their patients, but there's a heavy focus on education. But when you leave their house, you really feel the gratitude and the light bulbs go off, and that you're making a difference. It is exceptionally rewarding work, and I guess that's what I would say. If it's not a dedicated part of their job, it's an addition. So they do clinic hours, and then you just want them to see somebody on their way home. When you're that low volume, there's just inherent inefficiencies, and so that might be something, is carving out whole days or something in their schedules. I don't know. I'd have to know more.
Yeah. Who is responsible for completing the LACE tool, and when is it completed? Is it done on every patient that is hospitalized?
That is a fantastic question. So in theory, or not in theory, in practice, it is done in the hospital. It is a hospital tool that is validated in the hospital, and so we have done years of work trying to get the LACE tool automated through our electronic medical record and sources available to us. And I'm going to be really honest and transparent. It has been hard, and but again, we've worked with our IT teams, and they've really stepped up. And so we have an automated daily report that laces every single person in the hospital. Now, it's not perfect. because it can only calculate the score based on the information it has. And so we've charged the hospitalists with kind of looking at and validating, like, if Mrs. Jones is a 2 or not. If 2 doesn't feel right, then we've asked them to release them. And the other difficulty on that is some providers are better at that than the others. So it's meant to be done in the hospital, and we have everybody kind of looking at it, our hospital partners looking at it, our hospitalists looking at it. If somebody goes home, our care coordination teams look at it, and so it's kind of all hands on deck. And it's really, really important because our entire readmission reduction strategy hinges on accurate place scores. And so it has been an evolution for us, and it's still not perfect, but we're way ahead today than we were 2 years ago.
Thank you. If a community partner meets a Kaiser patient weeks or months after a discharge and that patient has never had a PACT visit, could they still be eligible for a nurse practitioner to visit them, or does it have to be within the 72 hours of discharge?
Yeah, that's a great question. So the model, the Eric Coleman and Mary Naylor models and other models, its value and its purpose and its power is that it's a transition-specific specialty consultation visit in the home within 72 hours. So it clearly mitigates the risk of readmission. So we have other things if you're weeks or months out than a PACT visit. So it's the answer is no for now. Although I think we're going to be expanding, like I said, either community paramedicine or we have homebound rounding teams. So there's other things. PACT is meant to be around transitions.
Do you partner with certain MDs to have your orders signed, or do you have standing orders? You wouldn't need
Nope, they're nurse practitioners. That's why we use them. They're independent practitioners. So they order and sign their own orders. Yeah.
Great. Thank you. I have another question. Is PACT only for individuals with Kaiser going into SNF?
I'm sorry, can you repeat that?
Yeah. Is the PACT program only for individuals with Kaiser insurance who are going into a skilled nursing facility?
Yeah. This is a Kaiser program with Kaiser providers. So we provide this service to our Kaiser members. Yep. And we have I hope to start SNF PACT program like end of February, March. So we're getting together and we're going to start this in the next month, 6 weeks.
Great. How many visits per day can a nurse practitioner do? And then we have time for about one more question, I think, Jody. So thank you, though.
Yeah. So they were doing 3 visits in an 8-hour day, and they recently went to 10-hour days, and they're doing 4 home visits. And so we average about, with the pre-work and the printing of the chart and the reviewing the labs and the meds and then the drive time, and then we do an hour, we slot out an hour time for the home visit, and then more driving, and then charting. We think, around 2.5 hours per patient we dedicate to this.
Wow, that's a huge time commitment. That's great. Mm-hmm. Last question. Do the nurse practitioners relace the patients once they are home?
Yes. Yes. Yeah, I mean, it's all hands on deck when it comes to LACE. I mean, we may have a score going in, but afterwards in your charting, you're like, they are not, whatever it said they were. And sometimes it's wildly off, and sometimes it's just off by a point. That's really important. One thing I didn't say, and I'll just end with this, is we target the 9 to 15s, but I always give an example of this gentleman I saw was a LACE score of 7, and he was probably the sickest person I've ever seen. He just was in the beginning of his trajectory of his chronic illnesses, and so you always need a provider behind the tool. So, new diagnoses, major changes in medications, PACT is available to anybody, but to be mindful and targeted of this precious resource, we kind of have those guardrails, but really, at least a 4 could get it if the doctor really felt that it was necessary. So thank you all so much for having me. I appreciate it.
And our thanks to you, Jody, certainly for sharing this incredible work with us today. Thank you also, all of you on the line, for joining us, and we hope it's been a valuable use of your time and that you'll be able to use this information from today going forward. This webinar has been recorded and will be available on the Healthy Transitions Colorado website within the next few days. Thank you to everyone. Have a great day.